Hello, everyone. This week we are going to be covering the topic of hope and its role in serious illness. And this talk will cover the overall concept and definitions of hope, what fosters hope and what impedes it, how to do a clinical assessment of a patient and family's hope, some hope fostering strategies, and then how do we deal with this issue of unrealistic hope and how do we respond to it? I'll start with a quote by Rona Jevny. "We ridicule those who have too much of it. We hospitalize those who have too little. It is dependent on so many things, yet indisputably necessary to most. Those who have it live longer. Words cannot destroy it. Science has overlooked it. A day without it is dreadful. A day with an abundance of it guarantees little." Hope tends to be kind of an elusive topic. It's hard to put words to it. It's hard to describe. I will say that we could take a look at this topic from a philosophical point of view, from a religious point of view, but really I'm hoping today to be able to give you just some practical information about this topic and ways to be able to address it in practice with patients and families. So I want you to just think for a moment and feel free to stop the recording if you'd like. Think of a situation where you experienced hope. In that situation, what was hope for you? I also want you to think about what influences your hope and what impedes your hope. I want to introduce you to the Living with Hope program, which is out of the University of Alberta in Canada. They have a Hope Research Center there that has many, many resources and articles. Many of the articles are in the reference list at the end of the slide deck. And they're written for practitioners, for patients and families, to really be able to understand what the research has to say about this topic. The video link that is included here is for you to watch if you'd like. I think it's about a 20-minute video or so. It's very good. I will mention that this is out of Canada, and it is a little bit dated and there is a little bit of lack of diversity, but the content is really good. So feel free to watch that if you have time and if this is of interest. The concept of hope is really best delineated in the hope process framework, which is described by these wonderful researchers who have dedicated their life to this work. Hope is an essential experience of the human condition. It functions as a way of feeling, a way of behaving, and a way of relating to oneself and one's world. Hope has the ability to be fluid in its expectations, and in the event that the desired object or outcome does not occur, hope can still be present. These researchers articulated 4 central attributes of hope. The experiential dimension encompasses both positive and negative emotions. So joy, confidence, strength, and excitement go hand in hand with uncertainty, fear, anger, suffering, and sometimes even despair. Relationships with others will time and time again be cited as a source of hope. The spiritual dimension offers connectedness to something greater than ourselves and encompasses finding meaning and purpose, as we've been discussing all semester. And finally, the cognitive dimension of hope encompasses intellectual and behavioral strategies, including goal refinement and cognitive reframing. For those folks, their hope is really in their head. Just keep these umbrella categories in mind as we continue to explore this topic. So what does hope mean, and what does one hope for when they're approaching the end of their life? Well, several researchers asked these exact questions of patients who are receiving hospice services, and this is what they had to say. They said that they're hoping for a positive future, though that future is of course redefined. That future may be a day from now or a week from now. They also hope for a positive future for their families. For some, hope was an inner force that kept them going during their illness, and also was described as a process for enduring the suffering that they experienced during their illness trajectory. What do patients receiving hospice services hope for? They hope for relief of pain, no surprise. They hope for a peaceful death. And for some, they hope for life after death. And this may be related to their spiritual or religious beliefs. But again, as I shared before, this also may be about their legacy and how their family lives on after they have died. So what influences someone's hope as they experience serious illness? First and foremost, their physical condition, how they're feeling in any given moment. Their sense of connectedness to their family, friends, community, and to us as their healthcare professionals. And that is why approaching them with compassion and authentic caring and empathy is so important. Having a sense of control, even if it's over little things, is so important to foster hope. Somebody might not have control over their body. They might not have control over their illness, but they might be able to pick what they eat for breakfast. They might be able to pick what pants they wear that day. And having this sense of control over these little things offers a sense of possibilities and options. Sensory cues are so important, and this is important to think about, especially in the hospital setting when so much of someone's personhood is taken away. So having pictures of family, having flowers if they're allowed in the family, in the patient's room, having just objects from home can be so helpful to create an environment that fosters hope. The language that we use is also so important to think about. So rather than asking a closed-ended question like, do you have hope? We can ask an open-ended question like, what are you hoping for? What is most important to you right now? We can also think about options. How do we talk about this so there will be more options instead of how do we fix this right now? Again, including the patient and the family in the conversation. So what are the things that threaten hope? These are really the flip side of what we were just talking about. So first and foremost, pain and discomfort, of course. We also need to keep in mind that there's kind of a bruising effect that happens over the course of someone's illness, and also there are life events that happen that might not be related to someone's illness that really are kind of compounding stressors. So someone who is experiencing a serious illness and then they experience the death of a parent or their partner loses their job. These are all really stressful events that are happening on top of an already stressful event. We know that personal history and individual experiences can threaten hope if there are, let's say, PTSD or mental health issues, if somebody is more isolated, either physically or socially, these can really threaten their ability to hold on to their hope. And also, just as being in control, again, even if it's little things, is hope fostering, certainly the loss of control, the loss of independence, loss of control over one's body can really threaten hope. An important aspect of fostering hope in our patients is to ask about it. And here is a quick mnemonic for you to be able to add to your toolbox. It is the HOPE evaluation, which stands for health, others, purpose in life, and engaging process, which refers to goals. So we're already asking about much of this, but just to formalize. So first, we want to ask our patients, how have they been feeling? We might want to break that down a little more. How have you been feeling today? How have you been feeling over the last several days? Sometimes just asking how are you feeling in general can be overwhelming. We want to know who is most important in their lives. We can ask, where do you find your strength, which often gets at larger purpose and meaning in life. And then we also want to get at what is most important to them. So what are some hope fostering strategies that we might be able to put into play with our patients and their families? So first, if this is important to our patients, fostering interpersonal connectedness. I know that that is such a challenge in this age of COVID, but being able to even foster virtual connections can be so necessary and important. Lightheartedness is also an important aspect. So this is when we want to use appropriate humor. We might want to be able to talk about things other than their illness. We want to, again, find out where their meaning, their strength comes from, find out who they are, what has gotten them through difficult times in the past. Make sure that we are treating them with dignity at each step, which affirms their worth as a human being. We want to think about what is achievable, what are achievable aims. If that is getting out of bed one day, if that is going to the beach, if that is having a pain-free day, with that, whatever that might be, we might need to look at very short-term and very achievable aims. Reminiscing is also an incredibly important tool. Sharing uplifting memories. We always want to be mindful that not everyone has happy memories of their childhood. Many people have very difficult pasts, and we always need to be mindful of that. But if there are uplifting memories that can bring joy, that can be hope fostering. A few more to share. As I was mentioning, leaving a legacy is so important. This is where dignity therapy work can be so helpful if somebody is able to go through that whole process. If not, then being able to tell their story, perhaps recording some stories, going through pictures, being able to share who they are with others can be so healing and helpful. There are also many symbols of hope, and we need to find out what those symbols are for individuals. So that might be related to their faith beliefs. It may be having a Bible at their bedside table. It may be lighting candles at home. It may be pictures of their family. It may be seeing pictures of the ocean. Whatever it might be for this individual, we can help to make that happen. I'll just share one story of a patient who was very ill in the ICU, not really able to communicate with us. We knew that she was not stable to be able to leave the hospital and that she was going to die in the hospital. And we found out from her husband that she just loved the ocean And so we were able to just bring those ocean sounds into her hospital room and put pictures of the ocean all around her room. These are not hugely expensive or groundbreaking interventions, but these are symbols of hope. And she actually became a bit more interactive after we did those interventions. As I mentioned before, related to using appropriate humor, we can also think about times when patients just want to talk about something else. They don't want to do the legacy work. They don't want to engage in talking about their illness or care planning or anything like that. They want to talk about the weather, or they want to talk about a new movie or something like that, current events, and that's important too. Of course, controlling symptoms, having supportive family and friends if they are available, setting short-term goals, as I mentioned before, searching for meaning and purpose, having positive thoughts. Again, it might be, in this moment, I'm not feeling as much pain. In this moment, I'm not feeling as scared. And then receiving honest information from healthcare professionals was identified in this particular study as being hope fostering for some patients, because it allowed them to prepare and plan, and that was important for some. And that's why I have the asterisk there that that's not going to work for everyone. So what are some hope fostering strategies for us as healthcare professionals that help us to do this work day in and day out? Many of the responses to this particular study overlapped with what we've already been talking about, with a few notable additions. The most striking for me was the idea of resources and having enough internal resources, physical resources, and enough time to actually care for patients and families. So these are systems issues that can really help or hinder our own hope process. Also, this idea of making a difference, that we are doing meaningful work, as well as when there's a sense of peace or acceptance of the situation by the patient and family. We know that that does not always happen, but that can be very helpful for us to maintain our hope as we do this work. So what about the caregiver's experience of hope? Caregivers describe this idea of hanging on to hope, living in the moment, remaining positive, writing their own story and their own experiences. They describe hope as this dynamic inner strength that keeps them going. They also talk about it as a resource that they rely on to be able to do their caregiving duties. They describe their hope as a stepped process that changes, again, fluid and dynamic process that changes as someone's illness changes and as their caregiving duties change. They talk about hope and despair as kind of two ends of a spectrum, and their emotions fluctuating between the two. And they also describe their hope as a protective factor against loss, grief, and stress. In caregivers of patients with Alzheimer's disease specifically, they described renewing hope every day. And they represented this process as a knot. And this metaphor was actually put forth by one of the study participants, which I think is pretty incredible. They talked about these interrelated kind of sub-processes, coming to terms, finding positives, and seeing possibilities as part of this knot keeping hope strong. They talked about this really, their sense of hope and this knot being tied to how a person is doing any minute or hour of the day. They talked about the fact that even though there will always be the cloud of the illness over them, these participants, these caregivers, focused on replenishing hope looking at possibility, looking for a positive future within the context of living day to day with Alzheimer's disease. They also focused on hope for themselves, that they'll be able to have the strength to continue caregiving no matter what's happening with the patient at any given moment. They also talked about coming to terms, learning about the disease, learning about caregiving, acknowledging that the disease is not going to go away, and doing the best they can in each moment. They talked about finding positives, connecting with others, for some, their faith. They also talked about the positive aspects of caregiving. For some, it brought them closer to the person who is ill. For some, it allowed them to see their own strength and what they were capable of. And in terms of seeing possibilities, we talked about this related to patients themselves, setting goals, making choices, and feeling like you have some semblance of control. What about the caregiver experience of hope during bereavement after someone has died? Those caregivers talk about hope as a gradual process to help them through their grief. It helped them, holding on to their hope helped them to regain strength after the death and build confidence in the new roles and responsibilities that they often had to take on after a person has died. Hope helped them to be future oriented, to be able to hope for something. And they also said that during this process of bereavement, they would search for new hopes, finding balance between their sadness and their grief, and again, looking forward to the future, looking for new perspectives that might have been clouded because of their caregiving experience, and seeking new ways to connect and seek meaning and purpose. Now I want to transition to this idea of unrealistic hope or contested hope, when a healthcare clinician or team's hopes and the patient or family's hopes differ from one another. In the medical world, this scenario of unrealistic hope is often discouraged. It's treated as pathology. Patients and families are labeled as being in denial or not getting it, and it often leads to a lot of frustration among healthcare professionals. Here are some clinical examples. The patient who has advanced cancer, who insists his severe back pain is from exercise or overuse rather than his spinal metastases, or the patient who believes that a cure for her illness is imminent, even after being told that her illness is incurable several times. The healthcare team fears that these unrealistic hopes will delay treatment or hinder acceptance of and preparation for death. Despite these concerns, these fears may be unfounded. Research in social psychology tells us that human interpretation of information from the environment is inherently biased and inaccurate. This means that people hear what they want to hear and often need time to adjust to the information that they're receiving. Taylor also tells us that there is this idea of positive illusions, which can provide a foundation for this successful adaptation. And there is actually evidence that denial and positive illusions are actually associated with positive outcomes and better adjustment to illness and less emotional distress. It's important to note that most people acknowledge and accept this distressing information. These unrealistic hopes are often abandoned over time without intensive information as people adjust to the information, but they need to do so on their own schedules. And what I like to call healthcare time does not often allow for this. We often expect that families and patients and families are going to adjust in the moment. We share serious news with them and we immediately want answers and a plan to know how to move forward. And if they don't give us that information and they can't do that right away, then they're again labeled as in denial or not getting it or not adjusting fast enough to be able to make decisions. So I think that recognizing the challenges that are inherent in the system and the real distributive justice issues that exist. So for the longer somebody waits to make a decision with their family in the ICU, the longer somebody is waiting in the emergency department. That is real. And I know that there are a lot of pressures, especially in the hospital setting, there's a lot of throughput issues to be able to get people in and out of the hospital. And I would just implore you that if there are any allowances for time to adjust, to make them and to give patients and families more time to be able to make this adjustment. I'll also mention that this is where conversations over time and early palliative care involvement can be so helpful, because the adjustment then happens over time rather than in one particular moment. All that said, it is important to consider and assess where patients are coming from in terms of their hope, and to kind of think about any red flags that we might be hearing in terms of their adjustment to illness and to any situations that might occur. So unfortunately, there's not much guidance in how to deal with these situations of unrealistic hope. But ERSIC offers us some red flag type questions to consider. Really the most important thing to keep in mind as clinicians, though, is that we want to keep the conversation going between the healthcare team and the patient if they're able, or more likely the family. So we want to be careful not to get into an adversarial situation where each side is kind of digging in their heels and they stop talking. So we always just want to use our communication skills, and again, the tools in our toolbox, to be able to keep the dialogue going. So first question to think about is the focus of the unrealistic hope broad or severe? Does it persist despite multiple pieces of information from multiple sources telling them otherwise? So this is really where we want to use our communication and empathy skills. So it may be that somebody is told that they have cancer, they don't believe it, they keep asking, is it true, is it true? Every provider who walks into the room is asked the same question, and oftentimes in this type of situation, the patient or the family, they're not actually asking for an informational response, even though that's what it seems like. What they really need in this situation is an empathic and emotional response. So instead of saying, yes, you do have cancer, and you get into a no, I don't, yes, I do, no, I don't, yes, I do, and you end up butting heads, what you want to do is listen for the question behind, or the emotions underneath the actual question being asked. So this is where you might think about saying, tell me more about that question. Or it might be where you say, the patient says, I don't have cancer, and you say, oh my gosh, I can't believe what you're going through right now. I can't even imagine how hard this is. And then you pause. And usually, again, this is sort of a red flag kind of question, assessment kind of question. Usually most patients who have received the information will then go into their feelings, how scared they are, how overwhelmed they are, how much they can't believe that this is happening to them. And that's how you create that relationship and continue with that dialogue. Another question to think about is this person's adherence to the unrealistic hope complete, or does the individual admit at times there are limitations or other possibilities? So this is what I like to call the dual truths model. We are very complex beings, and we often hold seemingly opposing information and emotions at the same time. So a patient or family can know that they have cancer and know that that is incurable, and still hope that there's a cure, and still hope that they're going to get better. And they may go back and forth between that language, which can be very confusing for us as clinicians. But again, we always need to build on our relationship and go underneath the surface question to understand the emotions behind that question. This is also where we want to partner with our patients and families and use language like hoping for the best, making plans just in case, or I'm hoping along with you for that miracle, which Denise will talk about more, the topic of miracles. I'm hoping right along with you that the chemotherapy is going to be effective in shrinking the tumor. And I'm worried. And I'm concerned. And then you go on to share what you're seeing clinically. And that framing of that dual model can often work when people are sitting with dual truths themselves. So here are some other questions to consider. I won't go through all of them, but just want to say that if the answer to any of these is yes, further assessment and possible gentle interventions, such as offering alternative hopes or intensive counseling. This is where perhaps the social worker on the team, the chaplain on the team might really be able to get in there and do some work around fears and anxiety and creating meaning and purpose and really understanding better where this patient and family are at and where they're coming from. I want to end with this, this question just to leave you with. So the idea of to tell or not to tell. We often hear that our colleagues are reluctant to share information with patients and families because they're afraid that doing so will take away hope. And we, as palliative care practitioners, often worry that not sharing details of the illness of the patient and family might offer false hope. So the bottom line here is that hope belongs to the person who is experiencing it. We, of course, need to be mindful that our words and our actions are hope fostering and not hope threatening, as we discussed before. But at the end of the day, hope is not ours to give or to take away. It's just for us to support. And with that, I will end with another quote. Hope irks many professionals. We are trained to know, yet the choice is ours to make in relation to hope. We can open ourselves to the mystery or stay with illusions of certainty. Some suggested reading on this topic, if it's of interest to you, 2 books, Finding Hope and The Anatomy of Hope, both of which I highly recommend. And here are the references for you on the next few slides. Thank you all for taking the time to watch this talk. I hope that this information was helpful and useful for you.